out. Today, I am going to speak about body fluids, electrolytes, and acid-base balance. And the objective of this talk is that the student should be able to determine the need of fluid in type and volume, and to decide the type of electrolyte disturbance and causes of electrolyte disturbance, and the type and cause of acid-base disturbance. Now we speak about water. Water occupies about 85% of the weight of an infant and 60% of the weight of an adult. And the body fluid is usually located in two compartments, that is in the intracellular fluid compartment and in the extracellular fluid compartment. The extracellular fluid compartment itself is made of intravascular compartment and interstitial compartment. And electrolytes are cations that carry positive charges and anions that carry negative charges. And the major cations are sodium and potassium, calcium, and magnesium, while the major anions are hydrogen, chloride, and bicarbonate. Now, the normal requirement of water is about 2.5 to 3 liters per day. And to make an equilibrium, the patient should lose about also 2.5 to 300 milliliters per day. And these are in the form of urine output of around about 1.5 liters per day. In breathing, one loses 500 milliliters of water, and in perspiration and sweating, one loses about 500 milliliters and 200 milliliters in feces. Now, dehydration, which is due to decrease in the total body water, the causes are usually due to dysphagia, due to failure of intake of enough amount, and heat stroke, in which there is prolonged sun exposure and excessive hard exercise leading to excessive sweating and loss of water. Also polyuria due to diabetes and diuretics, and other diseases causing polyuria, and also in vomiting and diarrhea, there will be dehydration. Usually, to investigate for water excess or water depletion, we have to look at the hematocrit and blood urea nitrogen. And in treatment, we have to check the fluid balance and correct the electrolyte. Now, the water excess is due to overhydration. Generally, it can cause edema, which is excessive accumulation of fluid in the interstitial tissue spaces. That is called also the third space. And cause of edema is usually due to disturbance of the hydrostatic pressure and oncotic pressure, the differences of filtration pressure in hydrostatic, and differences between hydrostatic and osmotic pressures in the capillary level. Now, this diagram shows it very clear that in the capillary nearer to the arteriolar end, the hydrostatic pressure is around about 36 millimeters of mercury, while the osmotic pressure of the blood is around about 500 milliliters of mercury, with a difference of 10 to 11 millimeters of mercury in favor of pushing fluid and nutrients to the cells outside of the capillaries. While near the venule, the hydrostatic pressure drops to 15 millimeters of mercury, and if the blood goes to the veins, it will drop more and more, and to reach the inferior vena cava, very low pressure, to reach a zero level at the right atrium. This is the venous return. So we come back to the capillary. In the nearer the venule, usually the hydrostatic pressure is 15 millimeters of mercury, while the osmotic pressure of the blood is 25 millimeter of mercury. This difference of 10 millimeters of mercury is in favor of pushing fluids and toxins of metabolism to the capillary to be carried along the veins to the kidneys to be excreted in the urine. Now, the electrolytes, as I said before, extracellular electrolytes are sodium chloride, potassium, and bicarbonate. And the major cation is the sodium, while the most important anion is the chloride. On the other hand, is the intracellular electrolytes, the most important are potassium, magnesium, sulfate, and phosphate. But the most important one is the potassium, while cation, while the most important anion is phosphate. And to control the fluid and electrolytes, usually the pituitary secretes antidiuretic hormone that leads to reabsorption of water from the renal tubules in response to low blood pressure and low blood volume. And also through the renin-angiotensin-aldosterone system, we have studied this in the basic sciences before, the pituitary gland secretes adrenocorticotropic hormone that goes into the pituitary cortex to secrete cortisol that lead to formation of aldosterone. Aldosterone will lead to reabsorption of sodium, which will in turn increase the blood pressure. In response to low blood pressure, the kidney and the low pressure is sensed as the extramedullary apparatus of the kidney, and it leads to release of renin that goes through the blood to the liver to convert angiotensin to angiotensin 1, and in the lung it will be converted from angiotensin 1 to angiotensin 2, which will also increase the blood pressure. Now, regulation of the fluids and electrolytes. The daily requirement of sodium is 1 to 2 millimole per kilogram body weight, and we said the normal serum sodium is 135 to 145 millimole per liter. The signs of hyponatremia are excessive thirst, extreme fatigue, low blood pressure, and sunken eyes. While the signs of hypernatremia are excessive thirst again and extreme fatigue again, but high blood pressure, lower limb, scrotal, sacral, and facial edema, and confusion, muscle twitching and spasm, and restlessness, and seizures, and brain hemorrhage. This is a bottle of normal saline. Here it is written it contains 154 millimole of sodium and 154 millimole of chloride. The total content is sodium chloride 9 grams in 1 liter. That means normal saline is 0.9% saline. Now the daily requirement of water for a baby between 3.5 to 10 kilogram body weight, we have to give 100 milliliter per kilogram body weight per kilogram body weight. Now, if the child grows up and the weight is 11 to 20, we have to give 1 liter plus 50 milliliter for each kilogram body weight over 10. Look at the first one. 3.5 to 10 kilogram body weight, we have to give 100 milliliter per kilogram body weight. If the baby is 10 kilogram, then means we have to give 100. We have to give 1 liter. And if it is if the baby is between 11 to 20, we have to give 1 liter plus 50 ml for each kilogram body weight over the 10 kilogram of weight. And if the weight is more than 20, we have to give 1.5 liters plus 20 ml for each kilogram body weight over the 20 kilograms. This 1,500 it is the same. When the baby is 20 here, we give 1 liter plus 50 for each kilo above 10. There are 10 kilos here, equal to 500, with the total, if the baby is 20, the total will be 1,500. And if it's more than 20 kilogram, we have to give 1,500 plus 20 milliliters for each kilogram body weight over the weight of 20 kilograms. Now, the normal saline is the commonest fluid used in hospitals, and it is used in resuscitation and during anesthesia and for cleaning of wounds. Now, as I said before, the urine output is usually the water intake daily requirement is 2.5 to 300 milliliters per day, and the urine output should be 0.5 to 1 milliliter per kilogram body weight per hour. And the normal serum sodium is 135 to 145 millimole, that is milliequivalent per liter. But we have 4 precautions that in shock, we have to start with a fast rate of IV fluids, fast drip. And we should not overload elderly patients, and we should not overload patients with heart and renal disease. And also, as a precaution, in hemorrhagic shock, if we give normal saline 2 liters and the blood pressure did not improve, then we have to start blood transfusion. There is no any further point in giving more normal saline alone. Now, in babies, we have to give half saline, not normal saline for babies. Now, the causes of hypo and hypernatremia. Hyponatremia, it is caused if we are giving only 5% dextrose water for fasting patient for a few days, particularly for postoperative cases. And also, if we are giving in severe vomiting and diarrhea, patients can develop hyponatremia due to loss of sodium in the vomitus and in diarrhea. Also, patient loses sodium in thiazide diuretics, causing hyponatremia, and hyponatremia can be due to excess water retention in heart failure and in renal and in liver failure due to retention of water causing a relative hyponatremia, dilution of the sodium. And also inappropriate ADH secretion in diabetes insipidus, there is polyuria that lead to depletion of sodium causing hyponatremia. On the other hand, hypernatremia is caused by excessive infusion of normal saline. And also in dehydration in dementia and in infants, if you are giving normal saline. And in Crohn's disease, which is a tumor in the kidney releasing aldosterone. Now, hypo and hyperkalemia. The normal potassium level is usually between 3.5 to 5 millimole per liter. And hypokalemia is usually due to potassium level less than 3.5 liters per liter. But the symptoms appear when the level is less than 2.9 millimole, that is milliequivalent per liter. And in hyperkalemia, we diagnose hyperkalemia when the potassium level is more than 5.5 millimole per liter. Now, the causes of hypokalemia and hyperkalemia. In hypokalemia, the causes are decrease in the intake of potassium, particularly patients who are receiving normal saline for a few days without receiving the daily requirement of potassium. And increase in the loss of potassium in the urine, in vomitus, and in diarrhea, and in the transcellular shift in alkalosis, Alkalosis causes, as in jaundice and pyloric obstruction, it causes hypokalemia. And in severe also hypokalemia, as the symptoms can be muscle weakness, fatigue, cramps, constipation, and ECG abnormalities. On the other hand, the causes of hyperkalemia are acute and chronic renal failure, massive crush injury, and burn and excessive gangrene, Addison's disease, adrenal failure, and antihypertensive treatment as ACE inhibitors. The ECG changes are usually in hypokalemia. The T wave will be flat, and the QT interval will be prolonged. While in hyperkalemia, the T wave will be long and tall, and the P wave will be flat, and the PR interval will be wide with ST segment depression. The treatment of fluid and electrolyte imbalance, usually in the treatment, we have to closely monitoring the patient and checking regularly his vital or her vital signs. And we have to monitor the fluid input and output hourly and regulate accordingly the fluid given to the patient. And we have to request serum electrolytes on daily basis to correct the deficiencies. And we have to regularly examine the patient and check in cases of edema, the body weight of the patient. Now we come to an important subject, which is the acid-base balance. Here, usually we have to ask ourselves, is the pH normal, or is it acidotic or alkalotic? If there are changes, is it metabolic or respiratory? And is it compensated or not compensated? Knowing that the normal pH is 7.35 to 7.45. This is a normal pH. And the carbon dioxide tension is 35 to 45 millimeter of mercury. This is a carbon dioxide tension, 35 to 45 millimeter of mercury, while the bicarbonate is usually 22 to 26, again, millimoles. Now, the respiratory acidosis occurs when breathing is inadequate and carbon dioxide accumulates, while respiratory alkalosis is due to hyperventilation due to excessive reduction of carbon dioxide. Now, metabolic acidosis. Metabolic acidosis usually there is decrease in the bicarbonate and build up of lactic acid and lowering of the pH. While in metabolic alkalosis, there is increase in the bicarbonate concentration, leading to elevation of the pH. This is an important diagram, and it shows that the pH, the normal pH between 7.35 to 7.45. More than 7.45, it is alkalosis, and below, less than 7.35 is acidosis. We have to check the arterial blood gases to see if there is acidosis or not. Then to diagnose whether it is alkalosis or acidosis, whether it is respiratory or metabolic, we have to look at the carbon dioxide tension and the bicarbonate level. If there is high, that is alkaline pH more than 7.45, and the bicarbonate is raised, most likely it is metabolic alkalosis. But if the carbon dioxide, the pH is high and the carbon dioxide is low, then most likely it is compensated metabolic alkalosis when the bicarbonate is high. Now, if it is if the bicarbonate if the bicarbonate is not that high and is high, but the carbon dioxide is very low, it could be due to respiratory alkalosis. Now, if the pH is less than 0.35, if the bicarbonate level is low, it could be metabolic alkalosis. And if the carbon dioxide in metabolic alkalosis, that is low pH and low bicarbonate, if the carbon dioxide itself is low, means it is compensating, it is trying to wash the carbonic acid through washing out the carbon dioxide. But if the pH is low and the patient has a chest problem and the carbon dioxide is high, then the patient will have a respiratory acidosis. And these are the same things we were speaking about. Now we have four assignments to enhance the student learning. And the first question is, a 17-year-old male has just undergone appendectomy. Write a plan for her postoperative fluid requirement in the first 24 hours, including the type and volume of IV fluid and its time. And the second question is that a 27-year-old male has just undergone distal gastrectomy and he will be fasting for 4 days. Write a plan for his postoperative fluid requirement, including the type of and volume of IV fluid and its time. And the third question is that, a little bit difficult, a 65-year obese female presented to the accident and emergency A&E with mild abdominal discomfort for 9 days. On arrival, she looks ill, drowsy, deeply jaundiced, with a blood pressure of 100, pulse 100 per minute, beats per minute, blood pressure 90/50, it is rather low, a millimeter of mercury, and respiratory rate 20 breaths per minute, and her abdomen is soft with mild epigastric tenderness and palpable gallbladder, deep jaundice with palpable gallbladder. Now, mention the investigations you would request on her arrival. And mention a plan for her resuscitation, fluids and electrolytes. And what is the type of electrolyte and acid-base disturbance expected in this patient? And the last question is a 78-year-old male presented to the accident and emergency A&E with continuous severe abdominal pain for 2 days. He is known diabetic and hypertensive. On examination, he looks ill, pale, not jaundiced. His pulse was high, 110 beats per minute, blood pressure low, 80/60 millimeter of mercury, respiratory rate 24 breaths per minute. His chest shows abnormal breath sounds. Abdomen was distended, tender with generalized guarding, and bowel sounds were not audible. Now, mention the investigations you would request for this patient on arrival, and mention a plan for her resuscitation. And what is the type of electrolyte and acid base disturbance expected in her case? To this point, I will stop. Hopefully, I will see you in another lecture shortly. Leave you in good health with great hopes. Bye. Bye.